All right, so it is 10 a.m. So good morning, everyone. My name is Amanda Quintana. I am a program manager with the New York Council on Problem Gambling. Very excited to have you all here joining us for day 2 of our conference. We are really excited. We have a lot of excellent sessions planned for the day. So without further ado, we're going to jump into our first session. I will say I am going to be juggling the chat, the admission, and behind the scenes stuff. So if you have any questions and need help, feel free to send me a private message and we can work it out. Today, we are joined by Dr. Grace Hennessy. She's the Associate Chief for Addiction Psychiatry at the Office of Addiction Services and Supports, or OASIS. Dr. Grace Hennessy graduated from Georgetown University with a Bachelor of Science in Biology, received her medical degree from Tufts University of Medicine, completed her residency in adult psychiatry at McLean Hospital, and completed an addiction psychiatry fellowship through the Partners of Healthcare Addiction Psychiatry Fellowship Program in Boston, Massachusetts. Dr. Hennessy served as the medical director of the Partial Hospital Program for the Alcohol and Drug Abuse Treatment Program at McLean Hospital for 3 years post-fellowship. After moving to New York in 2003, she was a research psychiatrist at the New York State Psychiatric Institute for 2 years before joining the mental health service at the Manhattan campus of the VA New York Harbor Healthcare System. During her 15 years at the VA, Dr. Hennessy served as the director of Substance Abuse Recovery Program and was also the section chief for hospital psychiatry during her final 2 years. Dr. Hennessy held several leadership roles in the New York University School of Medicine Addiction Psychiatry Fellowship before serving as a program director from 2017 through mid-2020. Dr. Hennessy joined the Office of Addiction Services and Supports as the Associate Chief for Addiction Psychiatry in June 2020. She's a clinical assistant professor of psychiatry at New York University Grossman School of Medicine. So without further ado, I'm going to pass this along to Dr. Hennessy. We're so grateful to have you. Thank you.
Thank you. And thank you, Amanda, for the introduction. And thank you all for attending today. I am going to share my screen, which usually goes pretty well. Before we get started, hopefully everybody can see my screen. Yes, I see heads nodding, great. So I'm just going to change this over to the slideshow and we get started. So again, good morning. I'm actually coming to you from Midtown Manhattan, 37th Street and Broadway, since people were putting where they were located today. Today, I'm going to be talking about the relationship between problem gambling and suicide. I have no disclosures to report in relation to this talk. The overview is that we're going to review the learning objectives, talk about deaths by suicide in the United States, the risk of suicide among individuals with substance use disorders and problem gambling, the relationship between problem gambling, suicide, and gender, co-occurring disorders, gambling severity and gambling activity, screening for problem gambling, and screening, assessment, and intervention for suicide risk. Our learning objectives today are to describe the overall risk of suicidal ideation and suicide attempts among those with problem gambling, understand the relationship between problem gambling, suicide, and gender, co-occurring psychiatric conditions, gambling severity, and gambling activity, describe methods for screening, assessing, and intervening with individuals with problem gambling who may also be at risk for suicide. Before we start our review of the literature on the factors associated with problem gambling and suicide, I want to show one slide that lists the diagnostic criteria for gambling disorder. In 2013, the American Psychiatric Association published the DSM-5, where the term pathological gambling was now renamed as gambling disorder. And this change was made in part because the term pathological associated with the gambling problems was considered to be negative and pejorative. It is also very stigmatizing and really doesn't have any place in the way we speak about individuals with gambling problems. This change, unfortunately, doesn't undo the use of the term pathological gambling in important research studies. So in this presentation, when the research study I am presenting uses a term, the diagnostic criteria as pathological gambling, I will use that term. I will use problem gambling or gambling disorder when it's otherwise used. But again, it's only going to be used in terms of the diagnostic criteria and not to talk about individuals who have problems with gambling. In terms of the diagnostic criteria themselves, they weren't really changed significantly between DSM-4 and DSM-5. I'm not going to run through them all. They've been up there for a minute and you can see them. One of the two changes were that the term gambles to relieve dysphoric mood or escape problems that was in the DSM-4 was just changed a little bit to say often gambles when feeling distressed, to be more inclusive of emotions. And the committed illegal acts to finance gambling was dropped because this was not felt to be a criteria that really added much or added to the overall diagnosis of gambling disorder, so that was removed. Suicide remains a major public health concern in the United States. This table from the CDC lists the leading causes of death between 2015 and 2020. Data from 2021 are not yet available. And as you can see, suicide is ranked as the 11th leading cause in 2020. It had been 10th for a number of years, but with COVID-19, you see COVID-19, it doesn't appear before 2020. Suicide drops to the 11th leading cause in the United States in 2020. Good news is that there's been a trend downward for suicide. So this is a very close-up tight number on the numbers that you saw on the other screen, but there was an increase for a number of years with a peak in deaths from suicide to about 48,344 in 2018. And happily, it's been on a decline since then, and we do hope that this will continue. Despite the decline, we do remain significantly concerned about individuals with substance use disorders dying from suicide. In this 2020 study by Francis Lynch and colleagues, the electronic health data of 2,674 individuals who died by suicide in the US between 2000 and 2013 were examined, and they found that substance use disorders were significantly associated with an increased risk of death by suicide. So if we look at the individual disorders, tobacco about twice as likely, drug use disorders a little over 5 times likely, alcohol 6 times as likely, and as you get into the combinations of disorders, the numbers even go up even higher. So drug and tobacco 5 times, alcohol and tobacco a little over 6 times, alcohol and drugs 8 times, and when you get to combining all of them, the risk of suicide goes up about 11 times in individuals who had died by suicide. Although we don't have comparable data for individuals with gambling disorder, there was a study by Anna Carlson and Anders Hackinson from Sweden, where data from the Swedish National Patient Register and Cause of Death Register between 2015 and 2016 were examined for all-cause mortality among individuals who had been diagnosed with gambling disorder. Out of the 299 individuals with gambling disorder, 67 or about 3%, so a small number of individuals had died during the study period, but the leading cause of death among those 67 individuals was found to be suicide. 21 or 31% of the individuals had died by suicide. And what they determined from the study is that the individuals with gambling disorder were 15 times more likely to die by suicide than any other cause of death that they examined in this study. And it was broad. They looked at cancer, they looked at heart disease, they looked at a wide number of disorders, but suicide was the leading cause of death among these individuals. Now, this is a small sample, this is one study, but it does really highlight something concerning and something that we need to be thinking about among individuals with problem gambling. With that study in mind, I started to wonder about the factors that may influence the risk of death by suicide among those with problem gambling or gambling disorder. There's this really interesting study from 1969 by Dr. E. Moran. The E is never actually explained, so I don't know what E stands for, but Dr. E. Moran did probably one of the first detailed studies of the associations between problem gambling and suicide that really hadn't been any before 1969. And what he did in this study was he surveyed 75 Gamblers Anonymous members in the United Kingdom. 72 were men and 3 were women who completed this questionnaire, and 15 had attempted suicide. And of those 15, mostly had bet on horses or dog racing, or had been involved in gaming, roulette tables as their primary gambling activity. 2 of the 3 women, or 75% of the women, had attempted suicide. And what Dr. Moran took away from the study is that, quote, it appears that the obvious link between suicide and gambling is depression, and that depression is, quote, a reaction to large financial losses after a bout of heavy gambling. He also said occasionally the depression may be primary, and the gambling is then used to relieve the symptoms of depression. So from the study, this is where I got the idea to look at the issues of gender, co-occurring psychiatric disorders, gambling severity, and gambling activity a little bit deeper. So fast forward 34 years from 1969 to 2003, and we have this study by McCollum and Blazninsky of 85 treatment seekers for pathological gambling in Australia. There were 28 females and 57 males. And when they asked about gambling activities, the females reported, 100% of the females reported that slot machines were their gambling activity. For the males, the majority of them also reported slot machines as their primary gambling activity, but they also engaged in horse and dog and harness racing, casino table games, keno sports betting, and internet casino and card games. So a little bit of a difference in what the men were doing compared to the women. Among the study sample, 12 females and 19, it should be 12 females. I apologize, there's an error on this slide. It was 12 males, my apologies, and 19 females had current suicidal ideation, and 7 females and 6, I'm sorry, I apologize, this slide got messed up. It should be 7 males and 6 females had specific plans. Again, my apologies. I will make my slides available to you, and I will correct this from the final version. And again, my apologies. The males were more likely to report plans for hanging or other rapid means of death, whereas the females were more likely to report plans to overdose. And these are sort of what we see in society as well when we look at deaths by suicide and gender differences in them. So this sort of aligned with what we know. The ideation was gambling related. So people who had ideation had a higher total gambling debt, more money spent weekly on gambling, more years of problem gambling, and, quote, depressive symptomatology was highly associated, but no clear connection with major depression. So sort of what we saw in 1969 really kind of carries over into studies 34 years later. As research into the relationship between problem gambling and suicide progressed, some interesting findings about the gender relationship emerged. In this 2015 study, a German study by Anja Bischkoff and her colleagues, 442 individuals with lifetime pathological gambling, 71 females and 371 males were examined for the association with suicidal ideation and suicide attempts. 133 of the sample reported having suicidal ideation during their lifetime, so 22 females and 111 males, and 82 reported a suicide attempt during their lifetime. And what's interesting, and this is actually all the females who reported ideation also reported having made an attempt. I should note that this group was recruited from telephone. This was a telephone survey where people came from the general population, gambling locations, and inpatient treatment facilities for gambling problems. I'm going to come back a little bit more to the data about co-occurring psychiatric conditions on this slide a little bit later. I will point out that when they looked at the relative risk of suicidal ideation, they found that it was significantly associated with a lifetime diagnosis of mood disorders, also with substance use disorders and anxiety disorders. Gender, in this case, was not associated with an increase in suicidal ideation, but the relative risk of suicide attempts was. So when you look at female gender, the risk of having a suicide attempt if you were a problem gambler was 3.5. So a much greater risk than the males in this study of making a suicide attempt. Again, mood disorders comes up again and anxiety disorders. I'm going to highlight them more a little bit later, but do want to point out that in this study, and they were not looking at gender in particular, there was this finding that female gender added an additional risk to suicide attempts among problem gamblers. Bishkoff also looked at this data again a year later, published another study. So this is the same sample study. So the 442 individuals diagnosed with pathological gambling in this German study. And they actually put all the individuals together who had either suicide attempts or suicidal ideation, and they called it suicide events. There were 215 of those, and they wanted to again look at the influencing factors for suicidal events. So again, in this study, they found this, again, lifetime diagnosis of mood disorders was significantly associated. But again, female gender comes up as an issue where there is a significant association. There is an increased risk of about 2.5 times compared to men in terms of suicidal events. They found in this study, when they looked at all this information combined, that there was no influence from substance use disorders or anxiety disorders in this study. Hackinson and Carlson, who I mentioned earlier, they did the study in 2018 that found that problem gamblers in the Swedish sample were 15 times more likely to die from suicide during that period of 2015 to 2016. Re-examined the data, and again, the same group of individuals who were diagnosed with gambling disorder to look at more issues related to suicide attempts. So they're out of the 1,600 men and the 474 women, 407 had made a suicide attempt. And what they wanted to see was how co-occurring psychiatric and substance use disorders influenced the risk of suicide attempt in gambling disorder. So this wasn't a gender study, but once again, they found, as in the other studies, that female gender did increase the odds. So there was an increased risk of suicide attempts in problem gamblers if they were female. We also see there are co-occurring disorders. So there's drug use disorders, mood disorder comes up again as an elevated risk, alcohol use disorders, and anxiety disorders. So from the study, there is sort of a point that comes across that there may be something that where females may be more at risk for suicide attempts and suicidal ideation when they have problem gambling over men. And again, there are other factors involved. I'm going to come back to those in a couple of minutes. Before we get back to the relationship between co-occurring disorders and problem gambling and suicide, I just want to highlight that it has been well known that, that co-occurring psychiatric disorders do occur with problem gambling. In probably one of the best studies that brings together a number of studies that have been done over the years looking at co-occurring psychiatric disorders, Dr. Nikki Dowling and her colleagues in Australia did a meta-analysis of 36 studies to look at the prevalence of any current DSM-4 Axis 1 diagnosis disorder among treatment-seeking problem gamblers. And when they put all these studies together, they found that 75% of the individuals who were seeking treatment for problem gambling had a co-occurring psychiatric condition. The highest rates were for mood disorders, alcohol use disorder, anxiety disorders, and other substance use disorders. So 23%, 21%, 18%, and 7% respectively. And when they looked at them individually, in terms of the individual diagnoses, the highest rates were found for nicotine dependence, 56%, major depression, 30%, alcohol abuse, 18%, alcohol dependence, 15%, social phobia, 15%, 14% for generalized anxiety disorder and panic disorder. So just wanted to, kind of lay the groundwork that co-occurring disorders, psychiatric conditions are very common in individuals who have problem gambling. As promised, said I was going to go back to this point I made quickly earlier about these co-occurring disorders. So this slide is just a composite of the information that I presented a few minutes ago, where with the different studies, so the two studies from Bischoff and her colleagues in 2015 and 16, and Hankinson and Carlson from 2020, where it sort of it becomes clear that the risk of suicidal ideation in individuals with problem gambling is elevated when there is a lifetime diagnosis of mood disorders, so relative risk of 5.1, suicide attempts in the Bischoff study of close to 12 if people had a co-occurring mood disorder, a lifetime diagnosis of a mood disorder, again the odds ratio, so that increases your odds significantly of a suicide attempt among problem gamblers. And in the Hackinson and Carlson study, again, the mood disorders as a composite is 2.7 times increased risk. Their substance use disorders also comes up as well in the Bischoff study and the Hankinson and Carlson study, and anxiety disorders in the Bishkov study and the Hankinson and Carlson study from 2020. So again, having problem gambling, have a co-occurring psychiatric condition does put you at increased risk for suicide. Two other recent studies that focused on co-occurring disorders include a study from France. This is a study by Guillaume Landreau and his colleagues, where they surveyed 194 treatment-seeking individuals with problem gambling in France. The factors associated with suicidal risk were what they were looking at. And 40% of the sample was identified as being at risk for suicide, and 22% of that group had made a suicide attempt. When they tried to, again, look at the factors that may contribute to this risk, co-occurring disorders significantly were associated with suicide risk. And again, we see major depression. A mood disorder is one of the leading factors. 76% of the individuals who are at risk for suicide had a current or lifetime diagnosis of major depression, with an odds ratio of 4. So they were 4 times more likely to have a suicide attempt. And anxiety disorders were also there as well. So 63% of those who had a diagnosis of anxiety disorder, 63% of those who were at risk for suicide had lifetime or current anxiety disorder, and again, an elevated risk of about 3, a little over 3. High rates of substance use disorders were found among the sample, but there was really no association with substance use disorders and suicide risk in this particular study. And in a study published just last year, Taraji Jolly and his colleagues at UPenn examined the United States nationwide inpatient sample, or the NIS data set, for the years 2006 to 2017. They found that 6,646 inpatients with a primary diagnosis of major depression also had a secondary diagnosis of gambling disorder. And they compared them to, yes, it's not a typo, it's actually 4 million inpatients with a primary diagnosis of major depression without a co-occurring gambling disorder. And what they wanted to see was the relationship with suicidal ideation, suicide attempts, and what they called suicidality, which was a composite of suicidal ideation and suicide attempts. And what they found was that co-occurring gambling disorder was not significantly associated with an increased risk individually with suicidal ideation or suicide attempts, but it was one of the strongest predictors of suicidality among those with major depression, with an odds ratio of 1.4. And while the odds ratio was only increased and significantly increased for suicidality, there were significant differences in the percentages of individuals with and without secondary gambling disorder and suicide, as demonstrated by this slide. So you can see the blue line is the number of individuals with major depression without gambling disorder. Orange bar is major depression with gambling disorder. And there were higher percentages in all the groups: suicidal ideation, suicide attempt, and the composite of suicidal ideation and attempt than there were among the group with gambling than the group without gambling disorder as a secondary. These all were significant differences. Again, the odds ratio, the increased risk, was only significant for the composite of suicidal ideation and attempt. But again, as you can see, there are notable differences among the groups between those with major depression with gambling disorder and those without gambling disorder. Oops, I went backwards. Okay. So there are fewer studies that examine gambling severity, problem gambling, and suicide, but there are 2 that show some very interesting findings that do demonstrate a relationship. Using data from the National Epidemiologic Survey on Alcohol and Related Conditions, or the NESARC, Jacqueline Mogadam and her colleagues at UCLA looked at the 1,578 individuals in the survey who had provided information on gambling behavior, lifetime suicidal ideation, and or suicide attempts. They broke them down into 5 groups of lifetime gambling severity. So there was the non-gambling group, who had never gambled 5 or more times in 1 year, low-risk gambling, who had gambled 5 or more times in 1 year but did not meet any DSM-4 criteria for pathological gambling, at-risk gambling, 1 or 2 DSM-4 pathological gambling criteria, problem gambling 3 or 4 criteria, problem gambling 3 or 4 criteria, and pathological gambling, which was 5 to 10 criteria. And what this table shows is the breakdown of the different groups, the number of pathological gambling criteria met, and the odds ratio of lifetime suicidal ideation, again, by the severity of the attempt. So the non-gambling group is used as the reference. You can see the low-risk gambling group really did not have an elevated risk of suicidal ideation. At-risk group had a slightly elevated risk, but this was not found to be significant. But again, as the severity of the problems increase, as you get into individuals who are found to have problem gambling and pathological gambling diagnoses, the risk of suicidal ideation goes up 1.6 for those with problem gambling and close to 3 for those with pathological gambling. When they looked at suicide attempts by severity of lifetime gambling, sort of a similar picture emerges. So again, the non-gambling group is the reference. And when you get to at-risk gambling, it's about the same, but you take a big jump when you get into individuals with problem gambling. So they're almost 2.5 times as likely to have had a suicide attempt in their lifetime. And individuals with pathological gambling, 2.7, really closing in on 3 times as likely to report a suicide attempt in their lifetime. So again, as people had more severe problems with gambling, the likelihood that they would have suicidal ideation and also make an attempt was much greater. A more recent study by Heather Wardle and Sally McManus of the data from Great Britain's Emerging Adults Gambling Survey, which is an online survey of young adults aged 16 to 24, sort of had similar findings. There were about 3,500 participants, 1,672 men, 1,922 women. And what they were looking at was the association between current suicidal ideation, suicide attempts, and problem gambling in the year prior to, in the prior year in the survey. What they found was that 62 men and 95 women reported a suicide attempt in the past year. 24 of the men who had a suicide attempt and 13 of the women who had a suicide attempt were identified also as having problem gambling. Similar to what the Mogadam study did, they used the problem gambling severity index scores to divide the individuals into 4 groups. The PSGI scores range for anywhere from 0 to 27. So 0 meant non-gambling or no problem gambling. 1 to 2 on the PSGI meant low risk gambling. 3 to 7 meant moderate risk gambling, and greater than 8 meant problem gambling. And as you can see from this table, the odds of suicide attempts again increases as gambling severity or gambling problems increases. What they did in this study as well is they broke it down into gender. So just looking in general, non-gambling is also again the reference point. At-risk gamblers, so those had very few criteria, were not really significantly at risk of a suicide attempt. But when we get to moderate risk gambling, women suddenly jumps up. You're twice as likely if you're a woman and you have a moderate risk gambling problem to have had a suicide attempt in the past year. And then it goes up again as you move into problem gambling. So the PSGI score greater than or equal to 8, where it's about 5 times as likely. What was really interesting in this study is the jump that it took among males. I know I have stressed multiple times and just said it again, that being female may incur an increased risk. But in this particular study, the males were much more likely to have reported a suicide attempt in the past year if they had more severe gambling problems. This study they didn't really look at. They didn't really say, gee, I know there were all these other studies where women are more at risk and maybe why it is for men. It was just really more, there were a lot of factors they looked at in this study, but it is sort of interesting, and this is a little bit different than what we've seen in the other studies. So I think it just highlights really that, and these is also a group of young people, so that people are at increased risk when they have problem gambling, and in certain studies there may be a skew more towards females or more towards males. But again, the problem gambling, having significant gambling problems really does incur this increased risk. Lastly, I want to look at problem gambling and gambling activity. So this is sort of a kind of a newer area when we're talking about suicide, but people have looked at problem gambling and gambling activity, the relationship there. So this slide is not about suicide. This study is just, again, it's sort of setting the baseline like I did with the co-occurring disorders. So this was a study, again, just from last year by Yusuf Alami in Canada and his colleagues, where they did a meta-analysis of 104 studies that examined correlates of problem gambling. And what they looked at was a number of factors, including age, psychiatric conditions, substance use, gambling activity, employment, marital status, gender, education, income, and a lot of others. They actually had 57 correlates that they looked at in terms of problem gambling and what it may be related to. And really what they found in this study is that the gambling activities had the greatest likelihood, the highest odds ratio of having a gambling problem. So internet or online gambling really encompassed a lot of things. It meant online poker, it meant online bingo, it meant online lotto. So anything that people did online, electronic gaming machines, all of that online had the highest risk. So the odds of having engaging those activities and having problem gambling was 7.6. Non-casino based electronic gambling machines, or EGMs. So these were gambling machines that were in, say, betting shops, so horse betting shops or animal racing betting shops or bars. Again, these studies were from all around the world, had an increased risk of about 7.2. The casino-based ones, 6.8. Poker itself, not online, but actually paying poker, 5.4. And casino table games, a little bit under 5. So the gambling activity clearly in this study is shown, and this is again a lot of studies that they looked at, that gambling activity certainly has a strong relationship with problem gambling. In terms of suicide, there's really only one study that puts this in. And again, this is an emerging area of study. This is a study from last year by Eduardo Valenciano Mendoza and his colleagues. They looked at 1,112 treatment-seeking adults with gambling disorder in Spain. And out of that group, 229 reported current or past suicidal ideation, and 74 reported recent or past suicide attempts. And in this study, they actually did specifically look at the role of gender, and they also looked at the role of gambling activity preference. And among that, they looked at non-strategic gambling, which involves little or no decision making, which is chance-based. And that certainly is things like slot machines, so EGMs, video poker, Keno. And these are also these continuous play games, right? So we know EGMs in casinos, people just continue to play. Slot machines, video poker is the same. And they compare them to strategic, where you have to have a knowledge of the game, and that's used to influence or predict the outcome. So things like sports betting, more strategic card games. And then they looked at a mixed group of non-strategic and strategic gambling. And they found they had some very interesting findings from this. So when they looked at gender, again, this sort of fits in with the Wardle and McManus study that I had mentioned earlier, that the men in this study, actually the males, were more likely to report suicidal ideation or suicide attempt. They didn't do odds ratio or relative risk, they just did percentages. But I think it's fairly easy to see that a larger percentage of males in this study compared to females had suicidal ideation. The numbers get a little bit tighter when you look at it in an attempt, but again, the males had a higher percentage of individuals who had made a suicide attempt. When they looked at the gambling activity, what they did was they collapsed the strategic and the mixed group together. So those, again, who did strategic, but those who did strategic and non-strategic, and compared them again to just the non-strategic. And the non-strategic individuals were much more likely, a greater percentage of them had suicidal ideation and a suicide attempt. So these continuous play, these non-strategic games seem to definitely have more of a relationship with suicidal ideation and suicide attempt. And then they did something that, I think is interesting, and what we need to see more of is sort of do a little bit more of overlay of putting these types of data together. So when they combined gender and gambling activity, what really jumped out in this study is that within participants who reported a preference for non-strategic games, the likelihood of suicidal ideation was much higher for women than it was for men. When you look at the strategic mixed group, it is still higher for women. This is not statistically significant. It's still higher, but it's not as great. As you can see, the difference between the non-strategic. And when you look at suicide attempts, you have the same issue, that women who engaged in non-strategic play had a much greater percentage of them had made a suicide attempt compared to the men. It was also higher in the non-strategic mixed group, but again, this was not statistically significant. The difference is there, but again, it's very, very striking with the non-strategic. So I think this study kind of highlights where we want to see things going, sort of bringing together these different factors and trying to see where they intersect. So, in this study, this brings together a lot of the things that we talked about, the gender issues, the gambling severity, and the type of gambling that people engage in. Mood disorders or other psychiatric conditions were not looked at in this particular study, but it would be interesting to see how that overlay comes in as well. So I want to shift gears a little bit with the time I have left. I just want to quickly review screening for problem gambling. I know that this is a mixed audience. Many people work in gambling, but I didn't know if there were people also maybe who work primarily in mental health settings. So just wanted to quickly review some screenings for problem gambling, and then wanted to talk about screening, assessment, and intervention for suicide risk. Because now that we've discussed that there is this increased risk among individuals with problem gambling, we should really do our best to try to screen for it and intervene when we can. So just briefly, there are 4 problem gambling screens recommended by the Division of Prevention and Problem Gambling Services at OASIS. One is the Lie Bet questionnaire, which is pretty straightforward. Ask people if they ever had to lie to people important to you about how much you gambled, or have you ever felt the need to bet more and more money when you gamble? Further evaluation, if yes to one or both of these questions. In the information that the New York Council on Problem Gambling sent out yesterday about Gambling Screening Day, they recommended the brief biosocial gambling screen, which OASIS also recommends, which asks questions that are from the DSM. So during the past 12 months, have you become restless, irritable, anxious when you've been trying to stop or cut down? Had you tried to keep your family or friends from knowing how much you gamble? And did you have such financial trouble as a result of your gambling that you had to get help with living expenses from family, friends, or welfare? The last 2 are the National Opinion Research Center Diagnostic Screening for Gambling Problems. So I won't go through all the questions, but they ask about controlling gambling, lying about gambling, and preoccupation. And the NODS perk, which is about preoccupation, escape, risk relationships, and chasing subscale. And again, my slides will be available. These are available online as well. And they are screening instruments, if you're not already doing problem gambling work, that you can use to try to assess problem gambling in different populations. In terms of screening, assessment, and intervention for suicide risk. So just in January of this year, OASIS released guidance for our programs regarding evaluation suicide risk. So what it starts with is a universal screening with an evidence-based screening instrument for co-occurring mental health conditions. And I think in terms of what we've just been talking about, that's also important as well, because we saw the relationship between problem gambling and co-occurring conditions, and also how suicide factors into that. So it's good to start with a screen where you are looking at co-occurring mental health conditions. And Modified Mini has been with OASIS for a long time. It is a 22-item clinician-administered screen that captures 3 major areas of psychiatric conditions: mood disorders, anxiety disorders, and psychotic disorders. Question 4 in the mood disorders section asks, in the past month, did you think that you would be better off dead or wish that you were dead? And in our programs, if you say yes to that question, then we automatically move to administering the Columbia Suicide Severity Risk Scale, or the CSSRS, which is shown on the next screen. People may be familiar with this. If you're not, it's really an excellent screen for suicide severity rating scale. It's pretty quick. It's 6 questions. It ranges from questions about thoughts about death and wishing you could die or not wake up, any actual thoughts about killing yourself, and then it moves into planning. Are you making plans? Do you have an intention on acting on them? And have you started making preparations to do this? It stratifies risks into low. So yes to these 2 questions. If you say yes, you're low. If you don't say yes to anything else, you stay in the low range. Moderate is the orange questions, and red means that you are high risk. For people who are rated as moderate or high risk, we want them to be assessed by a licensed clinician to determine what the next intervention should be. Obviously, in some cases, someone may need to go to the emergency department, depending on your setting, if you're not already in an emergency department, for a greater assessment of suicide risk. Or, they may just need to talk to a counselor, see a psychiatrist to get more evaluation. But if someone is moderate or high risk, and if they're in an emergency room setting or anyone else, we really want them to have a suicide safety plan created. And we recommend the Stanley Brown suicide safety plan for individuals to use. It has 6 steps: recognizing the warning signs of an impending suicidal crisis, using coping strategies, contacting others to distract you from suicidal thoughts, contacting family members or friends who may help resolve the crisis, contacting mental health professionals or agencies, and reducing the availability of means to complete suicide. This slide didn't come out as large as or as nicely as I would have liked, but you can see pretty clearly, now that I have it on a bigger screen, that you can see the safety plan template. So again, the steps, the warning signs, coping strategies, people to call, people who you can ask for help, professionals or agencies you can use, which includes the Suicide Prevention Lifeline phone number, and making the environment safe. It also includes the one thing that is most important to me and worth living for today, that people should include. It's not considered one of the main steps, but it's something that they did add on for people to do. Individuals who are rated by the CSSRS as moderate or high risk should also receive lethal means counseling, so counseling on access to lethal means. And the way you do this there's no form on this, but there is a way to do it. You express concern about the safety of the individual and a wish to keep them safe. You assess whether the person at risk has access to firearms or other lethal means. You work with the person, their family, and or their support system to limit their access until they are no longer at elevated risk. And you make a specific plans with timelines and roles to do that. This can all be written out. Again, there's no form like we talked about with the safety plans, but you can write it out for people to make the plans. So again, sort of really thinking comprehensively about screening and assessing people and providing interventions for suicide risk. So in conclusions, problem gambling is associated with an increased risk for suicide. Factors that may influence this increased risk include female gender, although we saw from some of the studies that male gender seems to have a role as well. We need to understand more, but in a lot of the earlier studies, and I showed you some representative ones, female gender was a major issue. Current and lifetime diagnosis of mood disorders, particularly major depression, anxiety disorders, and substance use disorders. I think more research is needed there because it wasn't as robust, the findings, as it was with mood disorders, particularly major depression. Greater severity of gambling problems, gambling activity, identifying and addressing problem gambling among individuals with psychiatric disorders may help decrease suicide risk, and screening, assessment, and intervention for suicide risk among those with problem gambling may be an effective way to prevent suicide attempts. I have a bunch of references that are included as well. Again, I will make these slides available. I'll send them to the conference organizers. And I just want to say thank you. I did sort of keep this talk a little bit on the short side. I know you're probably surprised. It's 40 minutes after the hour, or pushing 45 minutes, and we're finished. But I did want to leave enough time for questions and discussion. And again, I want to thank you for your attention. And I will stop sharing my screen now. Thank you.
Thank you so much, Dr. Hennessy. This presentation has been so informative, so in-depth. We do really appreciate it. There have been some questions in the chat. Just from earlier in the presentation, someone asked if the diagnosis was going to change at all in the upcoming revised DSM-5 that's going to be released this month.
Yeah, great question. Thank you. I have not seen that in what I've read, that it's going to be sort of a major change. I'm going to be painfully honest. I haven't read, a ton about it, but from what I've seen briefly about the changes, I didn't see that there was going to be any change in the gambling disorder diagnosis.
Thank you. I appreciate that answer. We did also have another question just asking about the reason for the spikes that occurred in 2018 for those who had completed suicide.
Yeah, again, another great question. It's not clear. I think actually what some people look at more is why things have gone down. So, why the particular spike may not be as clear, but people have been feeling that the increased efforts in screening, assessment, intervention for suicide risk has really ramped up over the years, and that maybe that has more to do with the decrease as opposed to a spike. I think when I made that graph, it looks very striking because I really focused in. If you look at the scale, if I went back to the slide, it's from 40,000 to 50,000. So it looks really sort of like this very severe peak, but the year-to-year differences were not sort of tremendous. 2018, again, not clear, but again, people have been more focused on the reasons why they may be going down, again, with the hope that the screening, the assessment, the interventions, like we just talked about, are making a big difference for individuals who are at risk for suicide.
Thank you. Another question we had was just asking about some of the studies that you presented earlier. Just curious about the women in the study, if they were married, single mothers, their age, and so forth. So just wondering if you have any information about that.
Yep. No, I don't. A lot of the studies don't give that level of detail. So I think that's a great issue to bring up. And I think there are important, again, more layers to peel back in all of this. A lot of times it was female, male. That's it. Sometimes, some of the studies may have looked at things like income, but income was separate. As we talked about a few minutes ago, I think what we really need to look at more is these intersections. So, female, like we saw, female non-strategic gambling and, the suicide risk, the severity of gambling. They don't really parse that out. Again, it's a great question. I think there's more research to be done there. But it was not parsed out like that. And in the beginning, a lot of the studies I presented, the ones by Bishkoff and Hankinson and Carlson, they were not specifically looking at gender. They were looking at other issues, co-occurring psychiatric issues, or just other factors. And the issue of female gender just kind of jumped out. It was really only until that last study that I presented by Alami where they really parsed out the gender piece particularly. So again, hopefully that is the beginning of a path for us to be looking at those issues more closely. But again, don't have that level of detail on the group of females or males, to be fair. Were they single fathers? What were their lives like as well?
Excellent, thank you. Someone did ask just about the safety plan. So one of the questions was to put the safety plan back on the screen. I will just remind everyone that the slides will be shared at the end. But a follow-up question just in regards to safety plans was if OASIS has recommended minimum qualifications or really just any recommendations about the safety plans.
So we feel that safety plans should be done for everybody who is at risk. At moderate or high risk for suicide. The good thing about the suicide safety planning is that they don't require you don't have to have a particular background to do them. My background is the VA. I know there's other people on the call who've worked in the Veterans Administration, and really everybody did them. Everybody was expected to do them. So you don't have to be a physician, you don't have to be a social worker, anybody can do them. Obviously, you should read it, you should sit down. If the Barbara Stanley and Greg Brown do have a website, there's information there. But I can put it back up, but it's incredibly simple. It's really, really straightforward. And they meant it to be that way so that anybody could really do it. And the same thing is true with the CSSRS. If you put CSSRS or the Columbia Suicide Severity Risk Screen into your search engine and you go to the website, they have CSSRS for everybody. They have CSSRS for police officers to administer, CSSRS for teens to ask each other questions. So in coming up with our guidance about suicide screening, we really strove to pick things that were in the public domain, number one, that we could look up, anybody could look up, but that really did not need any really specific training. With the CSSRS, there's a really nice YouTube video that you can watch where someone goes through it. But it is incredibly simple. And that was the goal, again, in doing this, because with our programs, we have ranges, there's all different disciplines. And I'm sure a lot of people on the call are the same. There's a lot of disciplines that work in your programs, and the goal really is to make this universal.
Perfect. Thank you so much. Just another question we had, just any data on veterans with gambling disorder with suicide?
Yes and no. So I don't want to speak out of turn. I didn't, sort of when I was putting this talk together, when you do a talk, you have to make obviously decisions about what you're doing with it. There is a lot of data with veterans. I know that other people were speaking about veterans, which was part of the reason why I didn't do a lot of sort of studies on those. There is some increased risk. I've done talks on veterans. There's definitely an increased risk there, but I really don't want to say too much because I don't have data to give you. And hopefully, you may hear things about veterans and gambling from other speakers. So apologies that I don't have that, but it definitely is a concern, problem gambling with veterans, and then obviously with suicide as well.
Excellent, thank you. Next question we have is, do you think individuals with mental health conditions or predisposed with mental health disorder are at a higher risk for gambling disorders?
Right. So these are all these great questions, about really, and hoped that we would have a discussion. It's sort of like, how do you fit this all together? Which comes first, sort of the chicken or the egg, right? Are they gambling because they're depressed, or are they depressed because they are gambling? It was interesting from the one study by Jolly and colleagues. And again, these are all chart reviews. A lot of what I presented was, looking at data that the people were identified as having a primary problem with major depression, and then a secondary diagnosis with problem gambling disorder, excuse me. And one of the interesting things to say about that is that's sort of looking at diagnoses that people get when they go in the hospital. And again, it's about sort of what insurances may pay for and so forth. So you're more likely to put up the major depression diagnosis as first, than the gambling disorder as second, again, for billing purposes and payment. So, I think there seems to be, a relationship there. When you read the literature, and particularly when you look at when they talk about why people like to gamble, there's certainly that escapism, and particularly with those non-strategic gaming, like people really like to get lost in those. And so there may be some leaning for people who have a primary psychiatric condition, so the depression comes first, the anxiety comes first, that they may like those types of gaming activities better, because again, they can really kind of escape. People really zone out, when they are playing those electronic gaming machines. They're really just kind of very caught up in them. And it's in some ways, a way to escape your problem. You're in a different kind of mental state, just like when you drink, just like when you use substances. So I think, that may be, a cause. Again, we need more research, because a lot of these studies that we talk about, and again, I think we need a lot more research in gambling, period. But I'm sure everybody on the call on this conference feels the same as I do. But that, we really need to understand these things better, sort of which comes first, which leads to which. And there's probably, again, it probably goes both ways. But I do think psychiatric conditions can lead you, just like substance use disorders can lead you to engage in gambling behaviors.
Excellent, thank you. We do have a couple more questions. Just another one is just in terms of just the qualitative database that collects its information, in terms of, is it collected and housed together? Is there a way to access like a collective area of this information and data that's collected?
I'm sorry, I missed a beat. So
sorry. So the question reads, is there a qualitative database that collects its information? Robin had mentioned she used to input death certificate data for the New York State County to tally numbers. So just kind of wondering, is there a detailed information and, is it collected in a way and housed in an area that is compiled and together? In terms of like suicidality amongst people with gambling problems, is there like a data warehouse, so to speak?
Oh, I see. Okay, yeah. Not that I'm aware of, because I did a lot. I did a lot of digging and a lot of research with this study to see, what I could find, but I did not come across any kind of database. I certainly would have presented it. It was really more these individual studies, and as you can see, they're kind of studies that were around the world. So a lot of the studies worked off of their own countries' databases, like the Swedish studies. The Jolly study worked off of database from inpatient admissions, but I'm not aware of any warehouse where all of that is kept together. It's a good idea, to look at that, but again, it's really more individual studies, as we talked about in the survey.
Thank you. And there is one last question that we'll take, and then we will wrap things up. Just the last question we have is, if you know anything about corrections and their process for screening for suicide for those that are there for gambling, or if there is like a general suicide screening, or any thoughts you have on screening within the criminal justice system.
In the criminal justice system?
Yes.
Yeah, they can really use the same ones. I see the question, does corrections do suicide screening for gambling inmates? I'm not aware, I don't work in corrections. Hopefully they are screening for suicide, in general in the population. I think, as we know, people who are in the correction system often have co-occurring disorders. And so it is incredibly important that they are screened. It's screened for disorders. So I'm not sure. It's a great question. Hopefully they are. It's definitely encouraged that they do it, but are they actually doing it? I don't have good sort of information about. So sorry about that.
No, Dr. Hennessy, we really appreciate it. All the information that you've presented today has just been so incredible, very informative. There are really just excellent things in the chat saying thank you. This has been very informative. And a lot of the attendees have so that they've enjoyed the conference, the session so far. So again, we want to thank you so much for your time. This is going to bring us to the close of this session. We're going to have a quick break from 11 to 11:15, and then our next session will begin probably at 11:15. That's going to be the neurobiology of gambling, actionable tools for recovery, done by Dr. Heather Chapman. We really appreciate everyone joining. Yeah, just excellent things in the chat. Great presentation, great session, very excellent words.
Well, thank you, everybody. I always find it's still a real honor to ever be asked to talk at conferences. So thank you for attending. Thank you for listening. And again, I will make my slides available. I will correct those slides. I'm very sorry about that. And again, thanks, and enjoy the rest of your conference.
Thank you so much. So everyone, we'll see you at 11:15. Thanks.